Now beginning with the lecture on optics. Usually the first chapter that we read in our third year MBBS. Again, optics also we will study in the form of a story. But what are we studying in optics? We are trying to study about vision. How to record a vision. Yes, first of all, when the patient comes to us, we record vision. We do tests for vision, near vision, far vision, everything. Then, what we should know is, if the vision is normal, that means my eye as an optical system is normal. So, I need to know about the normal optical system of eye. But if when I record the vision, it comes out to be abnormal, that means I must be having refractory error. Yes. And then lastly, if I have a refractory error, then I'm going to correct the refractory error by some dark room procedures. Okay. So this will be the flow of our lecture on optics, everybody. We will first of all be starting with how to record vision, visual acuity. So let's start with visual acuity. Just a fancy way of saying vision. Okay, everybody? Visual acuity. Now, visual acuity can be divided into various types of visual acuity. So, when I say types of visual acuity or components of visual acuity, there are three components or three types. Number one, minimum visible. Minimum visible. What is visible to you? What is not visible to you? As simple as that. Number two, minimum resolvable. Resolution. This is what our vision is basically based on. Minimum resolvable or resolution component of the visual acuity means separation between 2 points. Separation between 2 points such that they are visible separately. I hope I'm crystal clear. If 2 points are too close to each other, they will superimpose and it will be visible only as a single point. So what is the minimum resolution by which you will be able to discern 2 points away from each other? Yes, minimum angle of resolution for eye is said to be 30 to 60 seconds of an arc. Okay, everybody? So if 2 points are away from each other by around 30 to 60 seconds, 60 seconds can be said to be 1 minute of an arc, then only they will be separately visible from each other. Okay. Now the third component is said to be minimum discriminable. Minimum discriminable. Okay, everybody? Minimum discriminable is an offset usually only of 3 to 5 seconds of an arc. This is actually known as hyperacuity. Hyperacuity. There are two examples. One is called as vernier acuity and the other is called as stereo acuity. Okay. So just remember three components. Please remember that the main component that everything that we talk about in tests is based on is minimum resolvable. Okay. Now, very simple, just theory, everybody. Just remember this much. Once we know this, let's start discussing the tests for vision.
Now, when we are talking about tests for vision, guys, we are trying to ascertain the visual acuity at the far point, that is the far vision, everybody, and the visual acuity at the near point, that is the near vision. So there have to be tests for far vision and tests for near vision. Very simple, right? So let's first start discussing the tests for far vision, guys. Now, as soon as I say test for far vision, I am hoping that everybody knows the basic simple name of the test that we do. Third first posting or intern, or whether you are even a first year student, guys, you have been to an ophthalmologist, you have got your vision tested. So I hope you know the name of that test, everybody. What is the test, everybody? The test, yes, I know a lot of you are saying the test is known as Snellen's chart. Now, Snellen's chart test, everybody has seen, at least seen, if not used. If not used, then I will appeal to everybody. You should know how to record vision on a Snellen's chart, everybody. And that is what we are learning here. How to record, what is a Snellen's chart, and how to record vision on a Snellen's chart. So everybody, as I said, I presume that all of you have seen a Snellen's chart. If not, then we will see what a Snellen's chart is and how do we record vision on it. So you see this is an LED vision chart. In your government hospitals, you will find manual vision charts, or you may find some boxes also. But these are the latest, in which we have an LED screen showing the Snellen's chart. How do we know that this is a Snellen's chart? We see 7 rows of letters, 1, 2, 3, 4, 5, 6 and 7, showing letters. The topmost letter is the largest, and as we go down, the letters keep on becoming smaller. Now, an important point to note, on the left side of the screen, you will see that in each row of letter, there is a number written. Topmost 6 by 60, second 6 by 36, 6 by 24, 6 by 18, 6 by 12, 6 by 9 and 6 by 6. Now what do these numbers denote? That is the question. So the numerator, everybody, numerator is common in all the lines, 6, everybody. So the numerator is telling us that this Snellen's chart testing needs to be done from a distance of 6 meters, or is being done at a distance of 6 meters. What does the denominator tell us? Denominator tells us that the first row of letter, which is denoted by the denominator 60, should be read clearly by a normal person from a distance of 60 meters. So on, if we move on to the fourth row is 18. It means that the fourth row of letters should be read clearly by a normal person from a distance of 18 meters. Okay. So this shows the normal distance, and the numerator shows the distance of testing. If you see the right side of the screen, instead of 6 by 60, it is written 10 by 100. It is just a conversion, everybody, of meter into feet and nothing else, right? Now we will understand how to record vision with a patient on Snellen's chart. So guys, how do we test vision on a Snellen's chart? So the patient is sitting with us. The most important point is we cannot test the vision binocularly. What do? We ask the patient to lift his or her hand and close one of the eyes. Okay. So in this case, I will be only testing the vision of the right eye. If the patient closes the other eye, I am again uniocularly testing the vision. So the vision always needs to be tested uniocularly, and the distance has to be 6 meters. So now the first patient is sitting with us, and we are going to record his vision. So now with the patient's left eye closed, sitting at a distance of 6 meters, we are going to ask the patient to read from the top. Start from line 1.
R S H K Z D R Z N S H K S D N N T S Z K R S H N R D K Z.
Very good. So guys, as we are able to see that a patient sitting at a distance of 6 meters has been able to read the last line, which needed to be read from 6 meters. That means in such a patient, the vision of the right eye is 6 by 6, or what we call as normal vision. I hope we understand. Now let's take example of patient number 2. Okay. So the same patient becomes our patient number 2 in this case. So now Karan is our second patient. Because we have tested the vision of the right eye, in that the vision was 6 by 6. Now we are going to test his vision of the left eye. Again, Karan is sitting at a distance of 6 meters, and he will be reading the chart with his right eye closed and only the left eye open. Sir, start.
R S H K Z D R Z N S.
Can you read this line?
No, I cannot read this.
You cannot read the fifth line?
No.
No letter?
No letter.
Okay. So the patient is saying that he can only read the top 4 lines,
but he cannot read the 5th, 6th and the 7th line on the Snellen's chart. What does that mean? That means that the patient's vision is 6 by 18. Why 6 by 18? Because the patient is sitting at 6 meters. So the numerator remains 6 and he is able to read the 4th line, everybody, which should have been clearly read by a normal person from a distance of 18 meters. So as we are able to ascertain in Karan, the right eye vision is 6 by 6 because he was able to read till the last line, but his left eye vision is 6 by 18. So now let's make Karan another patient, patient number 3. The earlier two parts were actual vision recordings of the patient of the right eye and the left eye. Now this is a made up scenario. Okay. So now Karan, I ask you, can you read the topmost letter?
Yes.
What is the letter?
R.
Can you read anything below that?
No.
So see, now the patient is saying that the patient can only read the topmost letter. That means the patient vision in this case will be 6 by 60. Okay. Now let us assume again that he is another new patient. Can you read any letter at the top? Can you read any letter on the chart?
No.
So the patient says that the patient cannot see any letter on the chart. So what do we do in such a case? We ask the patient to stand up and move 1 meter forward. That's it. Now the patient is standing closer to the chart. Instead of 6 meters, now my patient is standing at 4 meters. Close your right eye. Now can you read anything?
No.
The patient still can't read anything. So I ask the patient to move 1 meter forward. Now the patient is standing at 3 meter. So on and so forth, the patient will stand at 2 meter and then at 1 meter. So let us assume now that the patient is standing at 1 meter. Can you read the topmost letter?
Yes.
Please read the topmost letter.
R.
Can you read anything below this?
No.
So now the patient is telling us that standing at 1 meter, the patient can read only the topmost letter. What does the vision become now, everybody? The patient is standing not at 6, the patient is standing at 1 meter. So now the vision becomes 1 by 60. 60 because he is able to read the topmost letter which should have been read from 60 and he is standing at 1 meter. So the vision becomes 1 by 60. Now let us assume that Karan was not able to read anything even from 1 meter. That means his vision is less than 1 by 60. If the vision is less than 1 by 60, then the Snellen's chart becomes useless. So what do we do in that case, everybody? Again, Karan, close your right eye. So we are assuming that Karan was not able to read anything on the Snellen's chart from the closest distance, that is 1 feet. So the vision is less than 1 by 60. In such a case, I ask the patient to count the fingers close to his face. So let's say I am holding the fingers and the patient is able to count. Karan, can you count the fingers?
Yes. 3.
Now?
1.
Now?
4.
So that means the patient's vision is less than 1 by 60. What do we say the patient's vision is now? FCCF, finger counting close to face. But let's say the patient was not able to count FCCF. Then what do we do, everybody? Now can you count the fingers, Karan?
No.
So now the patient is not able to count the fingers. In this case, we use hand movement. We use our hand to move in front of the eye and we ask the patient whether you can see anything. The patient will say, yes, that I can see some movement in front of my eye. Karan, क्या दिख रहा है आपको आँख के आगे?
Hand.
Hand कैसा है? Stationary है या हिल रहा है?
Move कर रहा है.
Move कर रहा है वो. So the patient says that the hand is moving in front of the eyes. Let's assume the patient was not even able to see hand movements. Then what we would have done, everybody? Then we have nothing left but to see perception of light. So now the patient is not even able to see hand movements. Then what do? We take a torchlight. We shine it in front of the patient's eye and ask, Karan, आपको कुछ दिख रहा है?
हाँ, लाइट दिख रही है.
लाइट दिख रही है? अभी भी लाइट दिख रही है?
नहीं, चली गई.
अभी कैसी है? चली गई या आ गई?
आ गई.
अभी?
चली गई.
अभी?
आ गई.
अभी?
चली गई.
So we see that as soon as I put the light in front of the patient's eye, the patient says that the patient can see the light. And when I take it away, the patient is able to appreciate the fact that light is not there. Such a case we label as PL plus, or perception of light is present. But if the patient was not even able to see light, everybody, then we would have said that the patient is absolutely blind. This is how we record vision in our clinical postings in each and every case. It is a systematic approach. You can't test hand movement straight away. You have to go step by step. I hope all of you have been able to learn on how to record vision and Snellen's chart. If you are a first student, or if you are an intern, I would hope that you apply this knowledge, you go there, and if you don't find a patient, then record each and every of your friend's vision to be able to learn this basic art of visual acuity assessment. So now everybody, now that we know in detail, we have seen the clinical way of recording Snellen's chart vision, everybody. We have seen the steps of recording Snellen's chart vision. Let us answer some simple questions which can be asked, everybody. What is the normal visual acuity? The normal visual acuity, even though we record up to 6/6 as we saw, but usually we say everybody has a 6/5 visual acuity, everybody. Okay? What is the best possible visual acuity in humans? 6/3, everybody. Okay. See, 6/3 we are saying because we do the test from 6 meters. So we are saying from 6 meters, the patient is able to read even the line that normally should have been read from a distance of 3 meters. So it is best. It is better than the normal, better than the 6/6 that we record, everybody. Next question, which we answered, everybody, when we saw the clinical method of the recording, everybody. What is the least vision recordable on Snellen's chart? Okay. So basically, after what point Snellen's chart becomes useless? After what point, everybody? Yes, it was not 6/60 as we saw. It was 1/60. Yes or no? After 1/60, we have to go to finger counting and then hand movement. Yes, everybody. I hope we are pretty clear about these simple questions here. So if I ask you the next question, which everybody knows, just for the sake of writing, we are writing, what is the distance of examination? The distance of examination is 6 meters. Okay. We discuss everything in meters. India follows the metric system, everybody. Yes. So the distance of examination is 6 meters. Now, everybody, if we list the order of visual acuity as we have discussed, the visual acuity starts from 6/6, 6/9, 6/12, 18, 24, 36. So we know that if the patient is reading 6/6, that's the optimum that can read. Then 6/60. Then we move the patient forward 5/60, 4/3, 2/n, 1/60. At 1/60, our Snellen's chart becomes useless. So what is worse than 1/60, everybody? Finger counting close to face. Then we moved on to hand movements. And lastly, perception of light, everybody. Yes, I hope we are clear about this order of visual acuity. There should be no confusion in this and the method of recording the visual acuity, everybody. Now, after we know the clinical part, everybody, let's move on to the theoretical part. Regarding Snellen's chart, what is the principle of Snellen's chart? See the photograph here. Forget the photograph. First, let us write it down. The principle is that each letter on Snellen's chart, letter can also be called as a optotype. Each letter or optotype on Snellen's chart subtends an angle of 5 minutes of arc. Subtends an angle of 5 minutes of arc at the nodal point of eye when viewed from its respective distance. See, everybody, there are two parts to this principle. A lot of students, they do know the principle, but they have rectified it, everybody. They have just learnt it. And that is why they stop at this point. They say that each letter subtends an angle of 5 minutes of arc at the nodal point of eye. But that is an incomplete definition, because very important part is when viewed from its respective distance. That means that the topmost row of letter will subtend an angle of 5 minutes of arc when viewed from how many distance, everybody? 60 meters. The fourth row, everybody, 18, 60, 36, 24, 18, will also subtend 5 minutes, but when viewed from 18 meters. So each letter will subtend 5 minutes from its respective distance. Now, why is that so? Because each letter, the size of the letter is constructed in such a way that the topmost edge and the bottommost edge subtend an angle of 5 minutes. But each letter is further divided into 5 parts, 1, 2, 3, 4, 5 horizontally, and 1, 2, 3, 4, 5 vertically. Both ways it is subtended, or it is divided into 5 parts, such that each part of the letter, or I can say each stroke. See, if I'm writing E, this is my stroke, everybody. Yes, this is my first stroke. This is my second stroke. This is my third stroke, fourth stroke, and then my fifth stroke. So each stroke, everybody, the thickness of each stroke is also divided in such a way that that will subtend an angle of only 1 minute. Now, why 1 minute, everybody? Because we have just read that the minimum angle of resolution is 30 to 60 seconds of arc, or 1 minute of an arc, everybody. So to be able to discern each line, everybody, each stroke of the letter, this is how Snellen's chart letters are made, everybody. And the size, that is why it is decreasing, because the nearer we are coming, everybody, the smaller the letter can become, and the angle still remains the same. So I hope you have been able to understand the construction of letter and the principle. Yes? If you have been able to understand that, then let's understand this question, everybody. This question was asked in AIMS previously. What is the angle subtended by the topmost letter when viewed from 6 meters? Yes or no? So we know that the topmost letter will subtend an angle of 5 minutes from how many meters? Its respective distance, that is 60 meters. But what about the angle it will subtend at 6 meters? That is the question here. So let's see, everybody, a diagrammatic representation. Let's say this is the total height of my letter in the topmost line. This is the place where the patient is sitting, the 60 meters. So at 60 meters, everybody, the angle subtended will be 5 minutes, and the patient is able to read from 60 meters. But now we are saying that we are asking the patient to view this from 6 meters. So I hope this is very clear that this angle is much larger than 5 minutes. Yes, that much is clear to us. So how to solve such a question? To solve such a question, we have a simple formula. We say distance of letter divided by distance of testing into 5. Distance of letter, or for your better understanding, I will say respective distance of letter divided by distance of testing into 5. In this case, what does it become? Respective distance of topmost letter is 60. Distance of testing as given in the question is 6 into 5. So it becomes 50 minutes of arc. And that is the answer to this question. I hope there is no confusion in this, everybody. Yes? So we know that 5 minutes cannot be the answer. When this question was asked, people who knew the concept, whether they knew this formula or not, they left the question. People who did not know the concept, they had heard somewhere 5 minutes. So they asked 5 minutes. So such questions, if asked, everybody, our aim should be, if we are not able to get them right, at least not to get them wrong. Every minus mark is also important, everybody. Every 1 minus that you lose on a wrong question, everybody, puts your rank down by 200 to 500. So smart students, everybody, they know what to answer and what to leave. That is also an art, everybody. Yes. So I hope we have been able to ably understand Snellen's chart as far as our questions are concerned, and more importantly, our clinical aspect is concerned. Moving forward with CBME, with the next, everybody, this clinical portion becomes important. So even though I hope a lot of you have done the visual recording, if you have not, I will ask everybody to please go and record your own vision, your friend's vision, or anybody else's vision, so that you get accustomed to the fact of how to record a vision on Snellen's chart. Right? Now, this was the first test Snellen's chart. But what if you have a patient or you have a relative who cannot read ABCD? Does that mean we cannot record his vision for FAR? No. We have other tests for that. So this is the second test, everybody, for FAR vision. This is Landolt C-ring chart. If we see carefully, it is built similar to a Snellen's chart. The topmost letter is the largest. As we go down, the letters keep on becoming smaller. Or the shape in this case, the C shape keeps on becoming smaller. The only difference is, instead of reading ABCD, the patient is detecting the cut, everybody. So we are asking the patient, can you tell us the direction of cut, everybody? Yes. So the patient will say up. The patient will say left. The patient will move his hand and be able to tell you the direction. Yes. So we call it a detection visual acuity test. Okay, everybody. We are just detecting the visual acuity. Now, similar to Landolt C-ring test, we have another test, everybody. This is called the tumbling E chart. In this, instead of a lot of C's, we have a lot of E's, everybody. Yes. So where is the E pointing? Down, left, right, or up? Again, through directions, everybody, we are detecting the visual acuity. So number 2 and number 3, Landolt C-ring and tumbling E chart, both are used in illiterates. Okay. I hope we are absolutely clear about this. Yes. So somebody who can't read ABCD, then also we can use the same concept of Snell's chart and use it. Okay. Now, there is another test, everybody, which is not done in India, everybody. This is usually done in the United States, everybody. This is called the Bailey-Love Logmar chart. If you see the basic construction, everybody, it is still the same. The topmost letter is the largest, and as we move down, the letters keep on becoming smaller. The difference is, in this, each row has 5 letters. In our Snell's chart, the topmost row had a single letter, and as we move down, the letters kept on becoming more in number, smaller in size, but more in number, everybody. Here it is, each letter, each row has 5 letters. This supposedly gives more accurate visual acuity, but it takes a longer time. Okay, everybody, it is based on the logarithmic measurement of the visual acuity. We don't do it in India, not discussing in detail. The basic fundamental remains the same of subtend angle of 5 minutes at the nodal point of eye. Okay, so these are the 4 important tests that we end up doing, or we can do in an adult to record far vision. But what if we have a 3-year-old child? A 3-year-old child may or may not know ABCD, may or may not be able to comprehend all these directions, everybody. So that means we have to have a separate group of tests, everybody, for preschool children. So we are saying children which are still not absolutely clearly able to read and comprehend the ABCD part, everybody. Yes. So for them, we have 2 groups of tests. Tests which are based on matching letters. If they don't know how to read, at least they can match. Or which are based on matching pictures, everybody. Okay. So let's see the first group. In this first group, the patient has to match HOTV with the shapes, everybody. So each size, if we can match T with T, V with V, O with O, that is how we know that the child is able to see, everybody. Okay. This is known as Sheridan Gardiner HOTV test. Other tests in this group that can be done is a very important test, which we say is called the Stykar test. It is important that we know the full form for this, everybody. This is called as the screening test for young children and retards. So Stykar test. These are the 2 commonly done tests, everybody, for children based on matching of the letters. Now, instead of matching letters, children usually find it easy to match pictures, everybody. So I have shown you 2 tests here, everybody, for matching pictures. The above test, if you see, is similar to Landolt C-ring test. In this, the tires are made with C's which are cut, everybody. Yes. So this is called as the broken wheel test. The second test, everybody, is called as the K-picture test. Okay. Now, there are pictures which you have to match, everybody. Other tests which can be done is Allen preschool test. That is another test which can be done in this group. Okay, you just need to remember the names, maybe know the photographs. Not very common to be done, not very common to be asked. Now, what about infants, everybody? In infants, we don't expect them even to be able to match the pictures or match the letters. Yes, infants are another challenge, everybody. So for infants, we have special tests. The first test is called as optokinetic nystagmus test. Optokinetic nystagmus. What is nystagmus basically? We are talking about to and fro movement. Yes or no? Nystagmus, to and fro movement. We are inducing this nystagmus to be able to record the visual acuity. How? We can use two instruments, everybody. The first instrument is OK and drum. And the second instrument, everybody, this is called as the Catford drum. OK and drum, as you can see, has lines in it, stripes, whereas Catford drum has dots, everybody, black colored dots over a white background, which are large and large to small, everybody. So what is done, everybody? Let's say an infant is sitting, you have an OK and drum in your hand, and you're slowly rotating that, everybody. So the child can see a stripe pattern. So the child will follow a stripe till it disappears, then will come back to another stripe, then will follow a stripe till it disappears, then will come back to the stripe. So you keep on narrowing the width of the stripes, and based on which width is the child able to follow, everybody, you are able to determine the visual acuity. Same we do with Catford drum, everybody. We rotate, we see till what size of the dot the child is able to fixate and follow. So we see the nystagmoid movements, whether the child is following at this dot or this size dot or this size dot, everybody. Yes, and that is how we are able to calculate, or we are able to determine the visual acuity. Okay, if theoretically you are asked, OK and drum is used for finding out the resolution acuity, and Catford drum detection acuity. Because in OK and drum, we are able to see the thickness of the stripes. So we are able to find out the resolution acuity, also minimum resolvable, everybody. Okay, done. Now, the second group of tests that we can do are a very simple test, everybody. We call them preferential looking test. PLT. Preferential looking test. Preferential looking test means that the infant will focus on one of the things if we show the infant two things, everybody. Yes, he will prefer to see one of the two items that is shown. So this is based on the fact that an infant prefers to look at a striped pattern rather than a plain pattern. Okay, so in this image, this is the plain part, this is the striped part. So we know that the child will preferably gaze towards the striped pattern. So again, we do the same as OK and drum. We keep on narrowing the stripes, everybody, till the child is able to resolve the acuity. That means he's able to see the different stripes, black and white color. The child will, or the infant rather, I'm saying child again, the infant will focus towards the stripe pattern. And the same thing we are doing in the other test. This is called as the Keeler gratings, whereas this is Teller acuity cards. Okay, everybody, done. So these are the two group of tests that we can do, but we very rarely do them. What we actually need to know, or we actually should be able to do, what we actually clinically do in every infant, everybody, when they come to us, is an indirect assessment of visual acuity. Indirect assessment of visual acuity can be done through a blink reflex. As part of your CBME pattern, everybody, I hope that you are able to do this. This is one part of the CBME pattern. They ask you to develop as a skill, everybody, to be able to test the blink reflex and hence the indirect assessment of visual acuity in an infant. Why? Let's say there is a case of retinoblastoma, suspect retinoblastoma. So you need to know whether the infant is able to see or not, everybody. Yes, retinoblastoma can develop anywhere before 3 years of age. What if it is a case of congenital cataract? A congenital infantile cataract, everybody, the child is born with cataract. Again, the visual acuity will be compromised. So we need to be able to do this indirect assessment at least, everybody. How to do the blink reflex? Let's see, everybody. In this video, you will see as soon as the examiner is putting light on the infant's eye, you will see again the child is blinking, everybody, and that is what blink reflex is. That as soon as light is shown onto the eye, everybody, because visual acuity is present, the infant will end up blinking. Let me play it again for you, everybody. See again, right eye light blinks. Now light shown on the left eye, again the child blinks in response to it, everybody. Okay, so I hope we are clear about what blink reflex is. So closure of eyes in response to illumination. Okay, everybody, the child is born with it. This is present since birth. So if you are asked specifically in neonates, how do you do indirect assessment? Even in neonates, we are saying that blink reflex should be present. The second test that can be used for indirect assessment is known as Menes reflex. Okay. I don't have a video for this, but if I explain it to you, everybody, this develops around 5 months of age. So let's say a 5-month-old infant is there in front of me. I will close my fist and I will slowly move the fist towards the eye of the infant. Either the child or the infant will close the eye or will sway his head, everybody. Yes, he will move his head left, right, up, down, ever. So as soon as they see some danger, everybody, menace, you understand menace, some kind of mischief, right? So as soon as they see that somebody is trying to touch their eye or move towards their eye, bring an object towards their eye, yes, they will move or they will close the eyes, and that is called as Menes reflex. So this develops around 5 months of age. So what are we saying, everybody? The infant closes the eyes / moves the face on approach, which is a direct approach, everybody, on direct approach of an object towards his or her eyes. Okay, everybody, I hope we understand this. Very simple to do, everybody. So whenever an infant comes to you for consultation, without telling the parent, without telling anybody, you are doing this, you are performing this, so you know that indirectly somewhere the visual acuity is present and it may be normal also. Yes or no? We can't quantify it, but yes, we are able to find out whether the child has vision or not. Am I absolutely clear about this? Yes. So this is how we test, everybody, far vision in adults, preschool children, as well as infants, everybody. There are 2 take-home things here, everybody. Number 1 is the Snellen's chart, the most important test that you can do, and you can learn, everybody, and answer questions each and every day in your vivas and use it for your common knowledge also. And the indirect assessment. These are the 2 important clinical parts that you need to remember. Apart from that, a lot of theoretical small points that we have discussed in between. Now that we have recorded the far vision, everybody, what we should know is the very simple tests for near vision. Now, test for near vision can be performed in 2 ways. One is called as Jaggers chart. The other is called as Snellen's near vision chart. Jaggers chart, when we record the vision, we number the visual acuity from J1 to J7. Whereas in Snellen's, when we record, we say N6 to N36. Okay, so we are measuring it just like 6 by 6, 6 by 9, everybody. So N6 will be the best and N36 is the worst. Below N36, there is nothing. Below N36, we will just write down less than N36, everybody. Yes, usually, normally clinics in India use Snellen's near vision chart, and that is what I will be showing you today. In this image, everybody, usually electronic LED boxes are there, which have 4 sides, everybody. On one side, it is written in English, on the other side in Hindi and another language, everybody, okay? So you can see this is N36 written here, this is N6 written here. So normally a patient should be able to read at a reading distance of about 25 centimeter N6, everybody, okay? I hope you remember that there is something called as presbyopia. In presbyopia, the patient will be able to read lesser, everybody. Yes, so please, this test is important in specifically every patient, but also specifically the group of patients above 40 years of age who have started developing presbyopic changes, everybody. Okay, I hope we are clear about near vision tests. Now we move on to another important aspect of our vision, and that aspect, everybody, which we don't take into account normally, is called as contrast. So tests for contrast sensitivity. What does contrast mean? If you don't know, you can look at the image on the screen and you can understand. Contrast means, are you able to differentiate between a black and a dark gray, or a dark gray and a medium gray and a light gray? Yes, contrast sensitivity, everybody. So as soon as I see this chart, everybody, I know that I'm talking about contrast because I see that in the topmost row, the letters are the darkest. And as I move down, the letters are the lightest, everybody. Yes. So normally a patient should be able to read all the letters if the contrast sensitivity is normal. But specifically in cases of cataract, everybody, okay, you see that contrast is lost before vision. Okay. So a lot of times the patient may not know that they have cataract because their visual acuity may be 6/6 or at most 6/9. But when you do the contrast sensitivity testing, you will see that they are not able to distinguish anything, everybody. Yes. What are the tests, everybody? What is this test, everybody? So the test on your screen is P. P for Peli-Robson chart. I've shown you this photograph because this is again the normal test that we clinically use. But theoretically, there are other tests which you should know, everybody. A for Arden gratings, R for Regan chart, and C for Cambridge low contrast gratings. Even though you don't need a mnemonic, but the mnemonic has formed itself, CRAP, C-R-A-P. Please remember, this is the important point, Peli-Robson chart and the identification of this, everybody. Yes.
Normal optical system of eye. The normal optical system of eye is basically doing what? It is converging light rays. Yes or no? All the light that is falling onto the eye, it is converging so that an image can be formed on the retina. Or I can say it is doing what, everybody? Refraction. Yes or no? Refraction, convergence or divergence of light rays when light travels from one medium to another. So eye as an optical system is doing refraction by converging the light rays, refraction from two optical surfaces. What are the two optical surfaces, everybody? Lens and cornea. Am I clear to everybody? Yes. So now this converging of light rays has been explained to us by Gullstrand's schematic eye. So basically, to consider the eye as an optical system, we have removed all the unnecessary parts. We have just kept the optical surfaces. Based on the calculations by Gullstrand, we have been able to understand that the power of cornea is plus 43 diopter to plus 44 diopter. Yes? See, plus, why am I writing plus? Means converging power. But Gullstrand said that cornea has two surfaces. One is the anterior surface and the other is the posterior surface. Again, think about the anatomy, everybody. We read the anatomy of the cornea or the layers of the cornea from anterior to posterior, epithelium to endothelium. So two surfaces for light to refract. Yes. So the power of anterior surface is plus 48.83 diopters, whereas the power of the posterior surface is minus 5.88 diopter. Yes, you understand? So the power actually comes from the anterior surface. The posterior surface power is lesser. Now, why is the surface posterior in minus? That's the question. So everybody, if you've seen the eye, if this is my cornea and this is my aqueous, the refractive index of the cornea is 1.376, whereas the refractive index of aqueous is 1.336. So when the light is actually going from the posterior surface into the aqueous, it is going from a denser medium to a rarer medium. From denser to rarer medium, there is always divergence, slight divergence, and that is why the power of the posterior surface of the cornea is in minus. When the light is coming from air into the cornea, it is coming from refractive index 1 to 1.376. That is why the light is converging. I hope you understand this. Apart from this, there should be power of lens. Power of lens, we should already know, has already been discussed in the lecture on lens, everybody. Both the surfaces together have the equal power, plus 16 diopter to plus 19 diopter. Okay. So that's our powers according to the Gulstrand schematic eye, which says that there is convergence of light rays based on these three surfaces or on these two structures. Now, if somebody asks you which part of the eye has the maximum refractive power, I hope you know the answer. The maximum power is in the anterior surface of the cornea. Don't say cornea, please specify anterior surface of the cornea. Now, after Gulstrand, the optics were further clarified, simplified in detail by another person. So now we are reading Listing's reduced eye. Listing's reduced eye. Listing said that the power of the eye, apart from the two refractive surfaces, depends on some other factors also. What are the other factors, everybody? He said that there is something called the nodal point, principal point, and focal point. All the distances he measured from the first point of refraction. What is the first point of refraction, everybody? Anterior surface of cornea. Anterior surface of cornea. Anterior surface of cornea to principal point. This distance is 1.35 millimeters. Anterior surface of cornea to nodal point. This distance is 7.08 millimeters. Anterior surface of cornea to F2. If you are smart, you will understand this yourself. From the cornea to the retina, from the anterior most point to the posterior most point. This is basically the axial length. So this distance is 24 millimeters. But what about the second focal point, everybody? The second focal point, when a virtual and erect image is formed behind the objective. Okay, everybody? This is minus 15.7 mm. Okay? So basically, if I now ask you, according to Listing's reduced eye, where is the principal point in eye situated? Principal point basically corresponds to the center of the pupil somewhere. Principal point is located, see the language here, 1.35 mm posterior to anterior surface of cornea. If we talk about the MCQs, this is what will confuse you. Posterior to anterior surface of cornea, anterior to posterior surface of cornea, posterior to posterior surface, anterior to anterior surface. Am I clear? Similarly, if I say or ask you where is nodal point of eye situated? Nodal point is located 7.08 mm posterior to anterior surface of cornea. Then where is the focal point, everybody? F2 if I am talking about, located 24 mm posterior to anterior surface of cornea. But if I say f1, everybody, f1 is located 15.7 mm anterior surface of cornea. Yes, f1 is anterior to anterior surface of cornea. That's why we written minus 15.7 mm, everybody. All the distances to the left of the point of refraction are measured in minus. Basic optics of class 11th and 12th. This is what listings told us, that the power of the eye depends on all these distances also. When I discuss the refractory errors with you, you will realize this yourself. Okay? Now, listings also said that refractory power, if we consider the whole eye, refractory power depends on, first of all, the radii of curvature. Radius of curvature of the cornea, radius of curvature of the lens. As the curvature will increase, the power will increase. Am I clear to everybody? Curvature increases, power increases. Secondly, on the difference in refractive index between various structures. Denser to rarer, rarer to denser. And thirdly, it depends on the axial length of eyeball. Axial length of eyeball. Anteroposterior diameter f2 24 mm. Okay. So based on our listings reduced eye, we know that a lot of factors apart from the simple power of the cornea and the power of the lens can lead to some changes in the normal power of the eye. I hope I'm absolutely clear here, everybody.